Sensory, motor, and pain modulation brain abnormalities in trigeminal neuralgia, a proximal sensory-triggered neuropathic pain. All right, so how about to start out, let me give you a quick crash course on trigeminal neuralgia. So trigeminal neuralgia is a neurological chronic pain condition that affects the face. In most cases, such as mine, the pain is unilateral and it can affect one, two, or even three of the main trigeminal branches. The pain one feels is a shocking and stabbing electrical pain. And I like to describe it as having an ice pick in the ear, a bunch of cavities, a black eye, and then getting stung by 100 bees in the face all at once. Um, while the shocks are considered spontaneous, many patients do have sensory stimuluses such as wind and a makeup brush or even the change in barometric pressure as triggers. And unlike most chronic pain syndromes, trigeminal neuralgia patients do not experience sensory loss. We don't have really numbness or anything like that. And while we don't really understand why some people get trigeminal neuralgia and others don't, it's typically thought that the majority of the causes include stripping of the myelin sheath around the trigeminal nerve due to a compression and possibly by a nearby artery. And this was the case in my situation. A close by artery had wrapped itself around my fifth cranial nerve, and over time the rubbing wore down my protective myelin sheath. So this is a picture I took for one of my doctors when I was trying to describe the location of my pain. I could feel it radiating from behind my ear up towards my temple, and from my ear to my nose, and again from my ear down to my teeth, my upper teeth, and a little bit down through my lower jaw. So the trigeminal nerve is the fifth cranial nerve, and it has three main branches that radiate from the sensory root. So the ophthalmic nerve, the V1, is a sensory nerve that carries the sensory information to the central nervous system from the eyes, skin, and the scalp. And the maxillary nerve, the V2, is also a sensory nerve that covers the sinuses and the palate and the nasal cavity. And lastly, the mandibular nerve, the V3, is a sensory nerve that also has motor function, and it covers the area of the lower jaw and the tongue. So some patients can have it in just one of these three branches, while others may have it in all three of the branches, such as myself. Interestingly enough, there are some cases of trigeminal neuralgia that do not show a clear case of compression in the fMRI or exploratory microvascular decompression. In some cases, a tumor can mimic trigeminal neuropathic pain, but typically when that happens, the pain is persistent. And those with a clear TN1 case tend to be pain-free between their flare-ups. And that makes it a very unique condition. We appear to be perfectly healthy and perfectly fine between attacks. Studies show that some patients with chronic pain other than trigeminal neuralgia may have gray matter on areas of the brain that are typically associated with pain, emotion, and motor function. So these abnormalities may lead to subpar plasticity in the brain. And going back to the fact that trigeminal neuralgia is characterized by pain without sensory loss, this study finds it to be a condition that can help understand how pain affects the brain's central gray matter. The study hypothesizes that TN patients would have gray matter increase in the brain areas such as the thalamus, amygdala, primary and secondary somatosensory cortex, and prefrontal cortex that are associated with pain and emotion. So obviously we can't go around and give people trigeminal neuralgia. And trust me, you really would not want people to do that. That would be bad. So these people had to use a retrospective style for this study and review scans from patients who had already been diagnosed with trigeminal neuralgia and compare it to control healthy patients, volunteer patients. So they found 24 trigeminal neuralgia patients at Toronto Western Hospital, and they had to meet the following criteria. So first, they had to be a trigeminal neuralgia patient at Toronto Western Hospital between May 2008 and February 2011. And these patients had to have unilateral pain only on the right side and had to involve at least the maxillary and the mandibular branch. On top of that, their pain had to be described as sharp and intense stabbing sensation, and they were not able to have any sensory loss with their pain. And lastly, they could not have had any type of surgery to try to correct this trigeminal neuralgia in the past. So what they did is they matched each of these patients with a healthy control patient of the same sex that was close enough in age. And each of these 48 people, 24 patients and 24 healthy controls, had brain imaging that included a 3-TGE Sigma HDX MRI, and each patient also had a cortical thickness analysis to look at the cortical gray matter. And a mask was created so that only the interested areas were able to be analyzed. And these areas included the thalamus, the amygdala, the hippocampus, basal ganglia, and the brainstem. So this is kind of interesting. This shows the mask that they created that was restricted to the gray matter areas that they were interested in for the analysis. So it shows that A through D shows the cortical thickness masks, and it shows the right hemisphere and left hemisphere. But it's interesting how that was created. And then they did a VBM mask as well that shows the subcortical structures, and you can see that in E, and then the sagittal ones in F, and then the axial ones in G. So those were the areas they were targeting when they were trying to do this cortical thickness analysis. So let's quickly do a little review about brain matter. So the brain is usually about 60% white matter and 40% gray matter. And if you think back to chapter 3, you may remember that the gray matter is densely packed with cell bodies and dendrites. Meanwhile, the white matter is mainly myelinated axons. So I don't think a quick little overview of this is going to hurt us. Let's look at the amygdala and recall its involvement in fear and discrimination of objects necessary for organism survival. Hippocampus, which is involved in memory retention. And as well, let's look at the thalamus, which, as we remember, helps relay information between the lower and the higher brain centers. And the hypothalamus, which governs eating, drinking, sex, emotions, and stress. I'm going to take a quick second to give you a couple of interesting statistics that I think are kind of important explanations in this situation. So first of all, women tend to be affected more often than men with this condition. And also the condition is, if a patient is more likely to be older with this condition than younger. And so it's more prevalent in people over the age of 50. And if you think about it, this makes sense because it takes time to rub down the myelin sheath. And if a compression is lightly loose, like, maybe lightly wrapped around something, the rubbing would be very gentle. And so it would take a good amount of time for this to be rubbed down. Also, over time, this thickness decreases anyway, so it would be a lot easier to make it all the way through if a patient's already a little bit older. So this makes sense, but there are children who get trigeminal neuralgia. I was 19 when I was diagnosed, and I have people in my support group who are 7 and then older. The youngest I've met was 7, but it happens. It's not as often, but it happens. So here you can see the breakdown of the TN patients they used in this study. You can see that there are 9 men ranging from ages 24 to 67 and 15 women ranging from ages 27 to 68. So this chart also shows us how many years they've had this pain for, and also the age of their pain onset. Now, a lot of patients have the pain for a while before they get an official diagnosis. I think I went about 7 months between my first flare-up and the time I found a doctor that actually knew what was going on. So they go specifically by the age they were when the pain started. It also tells us what medications they are on. So anti-seizure medicines, such as the ones listed, work as an adjuvant analgesic. And so this means, like we learned in this course, that sometimes a drug can be used to help something that it wasn't originally designed for. So in this case, these anticonvulsion medications slow down the electrical impulses that are being sent through the nerve and in turn help reduce the pain signals that are being transmitted. And so we see patients on medicines such as gabapentin and Integradol and pregabalin. And so this chart here will show us what medicine they're on, and the chart also shows us which of the 3 branches that I explained earlier the patients are experiencing their pain in. So you may have seen commercials or heard about pregabalin, and you most likely have heard of it by its other name, Lyrica. When I was first starting out with this condition, it was fairly new that it was being used for trigeminal neuralgia. Lyrica was used more often for fibromyalgia. And so I wanted to show you this breakdown of how it works. So pregabalin binds with high affinity to the alpha-2 delta site in neurons. So it binds to the neurons. And then it reduces the calcium-dependent release of several neurotransmitters. So it keeps glutamate and substance P from being released or reduces its release. And that in turn increases the GABA levels in the neuron. And this in turn reduces the neuropathic pain and, also has anti-convulsion effects as well. Cortical thickness analysis shows that trigeminal neuralgia patients have a 14 to 16% greater thickness within the contralateral, so the left side, and also in the frontal pole and the M1 bilateral. And there were also areas that were 10 to 19% thinner, and this included the ventral orbital frontal cortex. So what was found? Well, it was found that during the duration of a TN patient's pain was not significantly related to the cortical thickness that they found. It was also not significantly related to the abnormal gray matter areas. However, trigeminal neuralgia patients were found to have greater gray matter in the thalamus and more gray matter in the left side putative face area, the amygdala, the frontal pole, and the basal ganglia. TN patients were also found to have cortical thinning in the orbital frontal cortex. These findings have also been discovered in patients with other chronic pain conditions. So this study the study's findings raise the question of, is it possible that the central nervous system is actually responsible for the development and the continuation of patients' trigeminal neuralgia pain? So this analysis breakdown shows us the significant group differences in these specific subcortical brain regions. And we see the blue clusters here on the left that show us that there's a larger gray matter volume in the patients with TN in comparison to their healthy controls. So you see on the right that the controls are shown with the black bar, and the TN patients are shown with the red bar. So what they're representing is the normalized amount of gray matter we see. So a healthy patient obviously has gray matter, and the black bar will show you how much is normally present in that area. So we can see the increase in the gray matter volume in A, which would be the thalamus region. And if you look closely, you can see it bilaterally in the scan. And we see it in B, and that's an increase in the amygdala. And in C, we see a cluster of the gray matter in the right nucleus accumbens and the interior putamen. And in D, we see it in the posterior putamen. And again, notice it's bilateral there as well, and not just on the side in which the pain is felt, which is interesting. So interestingly enough, the study showed that despite only having patients with unilateral pain in the right side, that there was larger gray matter in the thalamic region found bilaterally, and not just in the side where the pain is. And the study also noticed that TN patients' thalamic neurons had larger bilateral receptive fields in comparison to their control group, and mentions another study where the patients had TN2, which, if you remember, is the constant dual aching with facial numbness version. They found that those patients had significantly smaller thalamic neuron receptive fields. So it'd be interesting to see if that would be consistent and figure out the why, if that's making that big of a difference in how the pain is shown. Thought questions. Okay, so thought question number 1. Understanding the chronic pain condition of trigeminal neuralgia, what would be some steps you would take to alleviate the pain a patient has? Are there surgical options or medication options that you can think of? Thought question number 2. Tegretol is an anti-seizure medication commonly given to patients with trigeminal neuralgia. Many patients on Tegretol report to their doctors that they have experienced memory loss and cognitive impairments. I myself was on the max dose of this medication and at one point experienced hallucinations on top of memory loss. So why would anticonvulsion medications affect one's memory? And thought question number 3. So think back to the role of the orbital frontal cortex, and how would you think a person overall would change given having less gray matter in that area?